Hello, everyone. My name is Lindsay Shuck. Thank you for joining today's Family Office Network's webinar series. We are excited to have the OXIO Health team joining us again today. Noel Guillama, President of OXIO Health, Carl Larson, Executive Vice President and COO, Greg Steinberg, outside board member and Vice Chair, will be speaking for us today. At the end of today's presentation, we will have time for Q&A. Please use your questions chat option on your screen to send over any questions you have so we can answer them accordingly. With that said, gentlemen, I'll let you take it from here.
Thank you very much, Lindsay. We appreciate that introduction. We're here to talk about a really exciting company and a really exciting opportunity in healthcare today. In summary, what we are doing is we are acquiring physician practices. We're rolling them up into a facility where we will manage and own the real estate, and we're bringing in a material amount of technology into the space. And we think that the timing and the opportunity is phenomenal for that.
Noel, it seems that you're muted.
No, you were muted.
Okay. So the industry that we're talking about is healthcare, and the healthcare industry today is $3.6 trillion. The government estimates that it will double over the next decade, and the opportunity we think is phenomenal, and particularly with the Medicare population and growth. The way that we're looking at healthcare is really based on two components. One is the structure of healthcare, how healthcare is provided, literally in the physical space, and secondarily is the delivery system and how doctors are paid. And second monster component is about technology, the use of technology, and why we advocate that we have to bring both the service provider and the technology in the same place. If you look at today's big trends in healthcare are really around managed care, the patient wellness, the delivery model, and the digital health are the trends for the 2030. If you look at the headlines recently that we have witnessed because of COVID, sorry, I can't get my slide working. Here it is. Sorry about that. We're seeing the crisis that COVID has created in a healthcare delivery system, and that impact has been in everything from the primary care physician to specialists at the hospitals. The only segment of healthcare that's actually done incredibly well has been managed care. What we're witnessing today is a challenge at primary care, which is the focus of our business enterprise. 20% of physicians are actually thinking about shutting down. 55% are clearly unprepared for the next pandemic. And worst of all is 76% are experiencing tremendous amount of stress. At the same time, we're witnessing a material amount of contraction in the care being received by patients. Though telemedicine has helped fill in the gap, we also know that telemedicine is also not a long-term solution. So we see a tremendous opportunity in the space that we're looking in, which is basically acquiring these physicians that are under stress, consolidating them, and creating material amount of efficiencies. How we're going to do that is actually part of the second problem that we're facing today, which is almost an effective collapse in commercial real estate. This is a trend that we have all been witnessing in part because of what's been happening with online e-commerce. But the problem has now gotten exponentially worse, sort of in a post-COVID environment. So we're seeing a tremendous amount of space available, which is what we want to acquire. We want to consolidate. We want to bring in the physicians into that space and create a much better environment. We think that both of these events at the same time is basically a black swan that we can benefit from and create a much more dynamic, much more responsive healthcare delivery system. And in part of that really goes into basically three components that we're going to talk about. One is we have designed a fourth generation management service organization, which basically is going to be the company that acquires the physicians and consolidates them. We have a tremendous amount of experience. We've been doing this for over 25 years. And the opportunity is exponentially better because of what's going on with the demographics today. We're going to bring in a lot of new technologies into the space, technology that we already have, we've already developed. The opportunity here is literally to bring in revenues of between $10,000 and $12,000 per patient per year. We expect to be increasing the revenues of these practices we acquire by at least 200% over 4 years, and bring in the technology that we'll talk about later that we already have to both increase the quality of care and reduce our cost to provide that care, which is really a tremendous opportunity. In this graph, you will see that Medicare Advantage, which is basically the part of Medicare that is provided by managed care organizations, has been growing nonstop for over 15 years. And as we will show you, we expect to continue to grow because we're basically in the middle of the baby boom retirement period. And we expect that to continue to 2030. That's why our previous slide talked about 2030. And that number is going to continue to bring more Medicare beneficiaries into the Medicare program. And that's going to create tremendous value. Why that is important is because recently, literally the Kauffman Foundation analyzed the profitability and the gross margins per member per month. And if you see on the right-hand side, you'll see the spike that's been created by Medicare Advantage versus other traditional insurance models. So we're looking at an opportunity to go into the market at the right time, at the right place, when profitabilities are actually increasing. Recently, we were able to witness an IPO from an MSO earlier this year in August. And a few weeks ago, there was an announcement of a managed care organization going into a SPAC. And what we've done here is we've taken their publicly released information and we extrapolated our projections going out 3 years, which is about $180 million. And we've got an imputed potential valuation that is literally in the billions of dollars. In our model, we expect to be profitable based on our experience before. And like I said, we've done it before. If you go and look at it on a per patient valuations, we've done the same thing based on the amount of patients we expect to have, which is about 26,000 patients at the end of 3 years. Also, we have a multi-billion-dollar valuation, and we think that our return on investment is substantial, about 19 times the capital invested in the model and the opportunity. So that's the opportunity that's sort of at a high level. Then we talk about real estate. You'll see here a couple of pictures of facilities that we have got our eye on in our marketplace. And by the way, though we will start in South Florida, we expect to be growing through the rest of Florida and also through adjoining states, and particularly Georgia and South Carolina, with tremendous interest in Texas, for example. So what we're going to do is we're going to acquire these practices. We're going to consolidate them in a single facility in each region or each location. We're going to create efficiency. We're going to reduce the number of staff. At the same time, we're increasing the quality and the output. We believe it is fundamental in our business model to control the real estate. So they control literally the parking, the signage, and everything else. So our own medical practices will contribute about 40 to 60% in each location. The balance of the real estate and the facility will be leased to other physicians in the marketplace. Besides that, we were obviously going to have a tremendous focus into telemedicine. As we'll announce literally here, we expect to have our telemedicine component in our EMR, certainly by the end of the year. But we're literally, like I said, focusing here on the South Florida marketplace. The way we designed our company is something we call a distributed venture platform, which is basically a couple of components that are fundamental, which we talked about, which is literally the acquisition of the medical practices, the operating of the medical practices, the physical real estate. But as with almost any modern company today, the technology plays a fundamental role. And that's the next thing we're going to talk about, which is literally the EHR that we've already built, the IoT platform that we have designed, and we recently received a patent for it, and also a very big component in using a blockchain application for consumer utilization. So talk about technology, we've licensed 21 patents that have been issued and 19 that are pending. We also expect that in our model is to continue to add components. We call it future acquisitions that include other support services in healthcare that both bring value added to our network as well as bring out value added to our doctors. On the technology side, we've actually built an EMR platform. It's in the cloud, and it's designed to be used in this kind of a model marketplace where doctors can share the information, share the scheduling, and provide the billing and laboratory and pharmacy functions. We literally have just received a patent on parts of the components of this platform. The second key component is sort of our blockchain platform, which is what we're basically doing is we're taking the EMR with the patient consent, we're putting it in the blockchain so that they can take their information anywhere and anything, anytime that they want by aggregating data. And the last component of that is basically another patent that we just received, which is taking existing off-the-shelf products, devices, and connect them to both our EHR and to the blockchain to aggregate the data. We think it's fundamental, particularly in a telemedicine type world where we could use devices at a person's home to aggregate into the medical record to give the doctor more information. So we think that the remote care is going to be an exploding business, both for us and for the industry at large. And we plan to take advantage of that. In summary, what we're looking for really is to raise about $10 million in a convertible bridge note. We expect that no more than 2 years, and we'll show you why we're confident about that. We'll use that money to basically expand the company's acquisition pipeline and interact with the doctors, interact with the insurance companies, and finish adding components to our EMR platform. We designed it so that it has up to a 50% discount in months 13 to 24. And if we do as we want in the next 12 months, is we bring in the follow-on financing, the discount would be 25%. So the use of proceeds is basically, as I said, is literally build the corporate management team, begin creating the pipeline for acquisitions of doctors, identify the real estate, the design structure, complete the telemedicine portal that we have in the platform, and continue with the license of new patents into the platform. Our exit strategies are multifold. One is we expect and we design the company to be able to spin out these companies in the future, part of the DVP model. We also expect acquisitions to be a very big play. You'll see in the next slide. And one of the companies I literally founded was acquired by an insurance company. We also expect to have a tremendous amount of activity because of the growing market that we talked about in venture capital and private equity, as well as potential SPAC opportunities. My favorite plan would be to do an IPO, which we've done before. And that way we'll be able to incentivize the physicians and encourage retention. A few months ago, there was literally an announcement by Humana, a company I know very well, that they had allocated $600 million in a partnership with Walsh Carson to literally make more acquisition and expand their senior investments in senior care. So this is a management team that you heard Lindsay describe. We've got a tremendous amount of experience in the 4 key components of our space. One is in managed care. We've acquired, owned, operated literally dozens of medical centers, managed literally tens of thousands of lives, controlled networks of literally thousands of physicians, and been very involved in the healthcare industry all beyond our business. In the technology, we have actually built an EHR. It is up and running today. We have licensed 40 issued and pending patents. We've designed multiple cloud-based SaaS applications, and we want to develop and bring in a development team in-house as part of this. We also have a tremendous amount of experience in real estate, commercial real estate, both brokerage and property management, and construction projects literally from $100,000 to $30 million. So we bring a lot of experience. We also bring experience in investments. Talked about IPOs and managing large, complex companies with literally thousands of employees going through the registration process of the SEC. So we bring a lot of experience into the marketplace in the space that we're in today, both in managed care, in managing complex healthcare facilities, in healthcare overall, and certainly financial investments. And this is our 5-year projections that we're pretty confident about. That includes both the managed care component, the real estate component, and the 3 technology components that we have today. And we expect to have more components certainly over the 5-year period. So I wanted to go through relatively quickly and be able to answer any questions that you might have.
Great, Noel, thank you. Just for everybody that's listening on, there is a question box. You can type your question in, and we will address those as they pop up. So either now or as we go through this, other questions come to mind, please throw them into the question box. Noel, maybe this one's for you, and maybe it's because we're only a couple of weeks away, but what's the impact of the election have on your model?
Well, it's a really good question, but the answer is not as complex as you might think. The reality is that it either has zero impact, and I'll give you what zero impact would be, is if everything stays the same, which means President Trump is reelected, the House stays under Democratic control, and the Senate stays under Republican control. Nothing materially is going to change in our mind except demographic. If we go back to the slide, there's 10,000 people coming into Medicare. You saw the profitability of Medicare. So we already have a pretty strong wind to our back. If you have the other extreme, okay, which is, let's say, what people are calling sort of a blue wave, which is if you obviously have a Republican president, the House and the Senate, literally, if you go right now this minute to the website at cnbc.com, you'll see that one of the components they talk about is what are the comparisons between the two parties, and in particular the president and the vice president in Medicare. And one of the things that everyone is sort of counting on, and I would have to be one of those, that if there is a blue wave, that Medicare, it is proposed that Medicare will be expanded to those between the age of 60 and 64, which is dramatic and material. And without being political, probably a wise thing from the country to do. And I'll talk about it in a second. But what that does is that would bring about 20 million more people into Medicare. So it would take all of these projections and certainly increase them by 20 or 30%, maybe even more. The reason why it would be probably a great idea is because the problem that we have today as a society is that the insurance cost in private insurance of those people that are between 60 and 65 is disproportionate to the total cost of healthcare. And Medicare is already designed to take and provide care to those people that are over 65. So the reality is that society, let's call it, would probably save material amount of money by putting those people between 60 and 65 into the Medicare system, whether it is an expansion of benefits across the board, or even potentially buying into the system that's required. Employers in particularly pay a tremendous amount for those employees between the age of 60 and 65. And if you're one of those people that are self-employed, the cost can be prohibitive. Certainly it could be as much as a couple of $1,000s a month for someone who's 64 years old, when Medicare at large, the numbers at the high side is about $1,000 a month. And that's what the number that we showed you earlier, that the annual recurring revenue for a Medicare beneficiary is between $10,000 and $12,000. So it's either a relatively non-event, now more driven by demographics, or it's a big event that becomes a very big positive for our model.
Great, thank you for that. And One follow-up on that, and then there's a couple of questions on IP and technology. The follow-up is any impact on the Supreme Court process?
Not really, and the reason for that is the battle, if you could call it that, in the Supreme Court is mostly around the Affordable Care Act, or what some refer to as Obamacare. We would probably play a very insignificant role in the ACA, and the reason for that is that we have targeted our business model around the growing Medicare population and the growing baby boom population. As you saw, that's where the profits is. I cannot tell you we will not be involved at all in the ACA, because as part of our contract with the HMOs, it may be required that we be part of the ACA, but it really would have no impact. We're not designed for it. Whether it is overturned, whether it is changed, I am very confident to tell you that we'll have zero impact on our company and zero impact on our projections.
Great, thank you for that. And so flip over to just a couple of questions on the IP side. First question on that is, what were you able to patent? Software is not normally patentable. And were you able to patent connectivity?
That's really interesting. You're correct. Software is normally not patentable. Normally it's sort of copyrighted. Well, we were able to patent really what came from our bias on connectivity, is how things connect. So, for example, I'll give you two examples. On the sort of the EMR platform, and again, there's 21 patents that we have licensed, and it's how things connect. What the biggest problem that I believe is in healthcare, and I tell you this because I've been in it for 30 years, is a lack of connectivity, not only doctor to doctor, but doctor to patient. And the government has put a very big push over the last decade, literally started with the design sort of by the Bush administration, George W. Bush, but really accelerated by President Obama and his administration, was sort of mandating EHR. And what we found out is, after literally over 100, maybe $200 billion invested in EHR, is that all we did is we created just deeper and wider silos. That interconnectivity, which is sort of the big buzzword, is what's mandated. But the reality is that our model and our EHR was not designed just with interconnectivity. We designed a master platform, a master database, where the interconnectivity is automatic, so that our medical centers will operate on one system, one platform, and whether you are frankly in Dallas, Texas, or Miami, Florida, it will be exactly the same record available to the doctors, both in our platform, in our network of doctors that we will own, and in the affiliates doctors that we have. So yes, we've been able to do interconnectivity. The same thing is, and I talked about what we call blue box, which we don't want to build devices. When I talk about healthcare, most people's thought is that it's about pharmaceuticals, which is about 11% of healthcare, or devices, which is about 5% of healthcare. And yes, those are components. What I want is the data. At the end of the day, the way we're going to be able to change healthcare is going to be by the relationship between the doctor and the patient, which includes the use of technology, and the way we process the data. It's really, really hard. And you could ask IBM, is to do very fancy things with AI and machine learning in healthcare, because there isn't enough data. So whoever asked the question was very, very smart in understanding that the biggest missing link in healthcare is the connectivity. It's how things connect, how the EHR connects to the doctor, to the patient, and to the devices. Today, I'll give you an example. We're testing right now 5 different products that are off the shelf that can help our patients in the future, that will literally aggregate data to us. There will be a blood glucose monitor, a weight scale, a blood pressure, and a couple of other devices that are fundamental to monitoring the patient, especially when you're using telemedicine. So yes, connectivity is the single biggest problem of healthcare today, and that is one of the biggest components that we're bringing into the marketplace. And that's what we have patents on, is how data connects.
And a follow-up question for either one of you to that is, with the technology platforms that you have, what is that connectivity across the different companies and the, I guess that reading into it, sort of the sharing between the technologies of the different companies?
So that's a great question. One of the challenges that we have in healthcare, as I said, is that the data is sort of siloed. And if you're trying to do processing, you're dealing with multiple companies and multiple platforms. We are designing these companies with two big components. One, they're designed to eventually be independent because we expect to create with this DVP an opportunity to monetize our companies in the future. The second component, because they're controlled, all of them, by OXIO Health, and we're literally sort of the master operator of these companies, the HIPAA requirements and the transparency of data is the fundamental to our business model. So we're going to be able to take the clinical data from our doctors, processes in an EHR, and make predictive analytics. We have a couple of patents, 3 or 4 actually, that are literally about taking data and doing predictive analytics. So we're separating the problem. So think about today, if IBM wants to grab data or get data to do processing, they have to enter into some kind of a partnership with a hospital or an HMO to sort of, create the how that data is going to be used. We're not going to have any of such problems because we are the technology drivers of that data. So the patients coming into our medical facilities, the doctors coming to work for us, are all going to know that fundamental to our business and fundamental to us improving the patient health, fundamental to us providing the tools to providers or doctors, is how we gather, process, and make data actionable. See, right now we have an obscene amount of data in healthcare, but almost none of it is actionable.
Right. Yep.
Wonderful. Thank you. So a couple of follow-up questions back to the first topic relative to sort of the regulatory environment, federal environment, et cetera, funding environment. The questions, I'll sort of put them together relative to Medicare and Medical Advantage, which is what happens if Medicare funding actually goes down? How does that impact you? That's one side of the question. And the other side is, what's driving the increase in profitability for Medical Advantage?
What's driving the profitability to who?
Medicare Advantage.
Oh, Medicare Advantage. All right. So what happens, the worst case scenario of Medicare in the last 30 years has been that they have sort of flatlined Medicare growth, which is basically they've said we're going to increase growth by 1 or 2%. And what that has generally done is that has actually reduced the benefits to beneficiaries. Remember, the other side of Medicare is sort of the beneficiary. So that's basically created a material amount of political pressure that changes it. One of the other problems that they're having in sort of Medicare is creating more reporting requirements, which is an opportunity for us with the doctors, because they literally are almost having to have a full-time person just to handle the reporting requirements. What we think is going to drive, at the worst case scenario, is you're going to drive many more people. Right now, about 1/3 of Medicare is in managed care, okay, which is what's called Medicare Advantage, sometimes referred to Medicare Part C. So about 1/3. We think that one of the ways that Medicare is going to have to go in and control costs is to drive more and more people by providing benefits and opportunities into Medicare Advantage. Let me give you an example of how you do that. In South Florida, which is where we're based, which I call it sort of the capital of healthcare, if you're Medicare fee-for-service, a beneficiary generally pays 20% of all their healthcare costs. Medicare pays the rest, generally. If you join a Medicare Advantage program, and by the way, you're paying $80 plus or minus, whatever your Medicare Part B charges are. I think they're close to 100. So that patient, the consumer is paying that today. There are many plans in Florida where you have zero copay, zero deductible, and they're reimbursing you the Medicare Part B payment. So in fact, the HMO is paying you to do that. Now think about that. I showed you a slide that showed that Medicare Advantage profitability is at a record high at over $200 per person per year. So what we think is going to happen is, again, the worst case scenario is they're going to drive more people to Medicare Advantage by allowing the Medicare managed care organizations or insurance companies to provide a better pool of services. We think there is a tremendous amount of profitability as more and more people join Medicare Advantage, and as Medicare allows those insurance companies to be more proactive. Now, the reality is, at the end of the day, you have to control medical costs. And that reality, we think the change agent is going to be the doctors in the group, how many doctors and how well trained they are. Second is the use of the facility. So that's why facility is very important. And third and not least is the technology. How much technology? One of the positive impacts of COVID is that almost everyone has at least had one interaction using telemedicine. Now, telemedicine is not a magic bullet, but telemedicine is now going to be much better utilized. Before COVID, the telemedicine encounters in the United States were about 5%, more or less. They peaked back in, I think it was April, at 50% of all encounters. The number right now is somewhere around 20%. And most people, most professionals think the number will average out or sort of have a natural floor at between 10 and 15%. The great thing about, again, now if you have a connected home, a smart home with devices that are able to feed the doctor more information, we think telemedicine will increase at a new rate, so that it is very possible, for example, that by the end of the decade, telemedicine can account for 20%, maybe a little more than 20% of all encounters in Medicare Advantage going forward. But that's only because we're going to be building the technology and integrating the technology into the care of the patient.
Yeah.
That actually goes into one of the other questions, which is, how have you built telemed into your platform?
So telemedicine is really important, but as I said in the conversation, hopefully it's not a magic bullet. I've had people think that telemedicine is going to replace all of healthcare. It's not possible. And I talk to doctors every single day. And the reason in the Medicare Advantage space, let's think about this. People over 65, okay, we all have, parents, grandparents, some of us maybe have more than one issue. And it's really hard for physicians, and I talk to physicians every single day, to use telemedicine other than to do follow-up, initial consultations. But when you're having 2 or 3 issues, cardiologist, primary care, orthopedic, arthritis, all of those things create a tremendous amount of complexity. That telemedicine is not a magic bullet. My best guess estimate, again, after being in healthcare for 30 years, is that at the most, the baseline is going to be somewhere around 20% of telemedicine. We will have telemedicine in our EMR model, certainly before the end of the year, if not sooner, which will be integrated. Most doctors I talk to, and by the way, exclude maybe dermatologists, say, Noel, I can get 80, 90, 95% of what I need by just talking to the patient. In fact, you could argue that telemedicine certainly has been around for decades, because it's almost all of us has talked to a doctor, especially if we had a child, or we talk to a pediatrician over the phone and say, here's what's wrong with the child, here's the temperature, here's what's happening if they have asthma, and the doctor's been able to assess whether they could wait overnight or literally go to the emergency room. So what we're doing now with telemedicine today only is really creating the video component. Now, when you add all the other components of devices, like I said, those sort of 5 key devices that we talked about, now you're giving the doctor more data. He or she's not going to rely on it 100%, but they can make a determination whether that patient can wait overnight, can be treated via telemedicine, or needs to go to the emergency room. And let me tell you what, that is fundamental, because we're not seeing telemedicine as a revenue generator. Many companies, and we can talk about them that are out there, they're generating revenues from telemedicine. And I dare anyone to show me a company that's doing over $50 million in telemedicine that's making a profit. And you can't find one. The reality is it's really hard to make money on telemedicine that way. The way we will make money in telemedicine, materially we can make money on telemedicine, is by diverting patients from going to the urgent care or going to the emergency room if they don't need to. Okay, that is really fundamental. Or that's one side of it. The other side of it is by providing more interactive care to the patient. So that before, when we were at medical centers, we would have a nurse practitioner or an aide call a patient over the phone and ask them how the medication's working, how are they feeling. Now we will be able to have a little bit better interaction, a little sort of high tech, high touch, by literally calling the patient and having a telemedicine conversation with them. So we will be able to make money by, again, reducing our cost for urgent care and emergency care, but also proportionally by providing better quality of care and understanding if what the doctors are doing is working effectively. And one of the things that we found out about healthcare is that how the patient feels is material to their health and wellness. So we think telemedicine, we were doing it anyway, but I think that now with the utilization and the way we're going to use it, we have zero doubt that telemedicine will provide a material return on investment for us.
Wonderful, thank you. Another question, and maybe drills in a little bit into that, but maybe it's on a broader basis, which is, please share how COVID's impacted your model.
Well, COVID has impacted our model. I don't know how to say this politely and politically correct, but it's impacted our model in a material way. But almost all of it for us as a company is positive. I can tell you that we could acquire physician practices that we were already talking to because of the changing demographics for a fraction of what we would have paid, 7 or 8 months ago. So right now, doctors are realizing they need a partner. They need someone to help handle their problems, whether it is the PPE, whether it's their employment, whether it's the protocols. All of those are creating a tremendous buying opportunity that I like to refer to sort of as a Warren Buffett moment. The second part of that is also the second component of we talked about real estate. We were already going to go into this model. We were planning, we've been designing it, sort of unveiled it in January of this year, is now we're seeing what has been a material collapse in retail real estate. We are not going to be taking these practices and putting them in medical office buildings or putting them in hospitals. We want to create, and we have done this before, is create a brand. So we're going to be taking and repurposing existing retail real estate. So the only impact that COVID has had is a positive impact in those two components. One is our ability to acquire doctors, and you saw the slide where 20% of doctors are literally thinking of leaving the marketplace, and the real estate. On the other side, it's been a positive because if you look at the companies we would contract with, which is a Humana's, the Aetna's, the United Healthcare, they all actually showed record profits in the second quarter of this year. If I remember correctly, United Healthcare doubled the profits between the first quarter and the second quarter because they had less utilization. Now that is not sustainable, and if I was them, I'd be sort of worried about what's going to happen in 2021. But the positive of COVID is it's driving more use of technology. I mean, think about it. If I talk to someone in February, and we have been filing these patents for the last decade, is to say we're going to aggregate all these IT devices that are available in a home. They're like, okay, that's a great idea, but it could take decades for that to use. Well, today that's no longer decades, and today everyone's looking for that. So by us taking off-the-shelf devices and connecting them to the HR, connecting them to the doctors. So I don't know how to say this again any other way other than COVID has been a material inflection point for us.
Okay, we're going to go into a couple of questions that are around I think I'll put them in an operational bucket, let's call it that, or landscape bucket. Please talk about your competitive landscape and how you fit into it.
Well, that's a pretty broad question. So the competitive landscape, I showed you a slide, and Carl, maybe you can go back to that slide, is to 16.
Oh, 16.
So, right. I could tell you a few months ago, literally, it would have been really hard to go out there and talk to you about the MSO model other than tell you a lot about my experience in building these MSO models. But in August of this year, an MSO went public, funded by two very large venture capital firms, and collectively raised about $800 million. They're operating in a number of states, and the reception was overwhelming. I was shocked And I love this space and I love this model. But literally at the IPO, the market price value doubled. So that's telling you now what we call sort of a stalking horse. Their analysis, and I'll take their analysis as it is because it was obviously reviewed by Goldman Sachs, by Morgan Stanley, and JP Morgan, said that their addressable market was $335 billion, which is a market, I'll take it. I have a feeling that there is a tremendous amount of inefficiencies at a certain size. My personal number is somewhere between 10 and $15 billion. But what we're seeing is an opportunity. And by the way, from everything that I read, they built these facilities from scratch. They're leasing the real estate. They don't have their own technology the way we have it, and they've done by market conditions incredibly well. If you look at the valuation, it's material. A lot of insurance companies, for example, Humana, who bought one of the companies I founded, has now over 250 medical centers that they operate. United Healthcare has a division called Optum that operates literally hundreds of medical centers. But the reality is there are literally tens of thousands of primary care doctors that are sort of almost like orphans. And we have done this in the past. We'll do it again. Is we're going to acquire those doctors that do not want to work for an insurance company. They want a lot more flexibility. The average doctor we're going to acquire is probably going to be in his 50s. If you gave me an age, I'd probably tell you 57, probably. And we're going to make their lives easier by taking over their burden. We're going to pay them to acquire their practice. And I'll tell you right now, we're going to pay them a component. It's going to be a cash component. It's going to be an equity component, that's why it's fundamentals for us to be a public company, certainly by the end of year 3. And third is they're going to be sort of an earnout to make sure that their productivity is there. I've done an acquisition that you saw on one of the slides of nearly 100 medical practices. So there's nothing I'm going to need to learn about how to manage physician practices. We think there's room for a $5 billion company in this space if you have an addressable market of $335 billion. Hopefully that answered the question.
Well, we'll see if we get a follow-up on it. The question that goes over to revenue, I think, Carl, there's a slide on the breakout of revenue between the companies. The question is, how does the revenue break out between the individual companies?
Absolutely. So the driver, as I said, I think that's slide number 49, Carl, or it could be 51, 49, 50. So the driver, and that's why I sort of led with total care. The driver of the company is going to be, sort of total care, and it's going to drive the revenues because at the end of the day, that's going to be where the doctors are, where the patients are. Everything else plugs into that business. So overwhelmingly, the revenue is going to be driven by total care. Secondarily would be the real estate, because again, as I said, we're going to operate between or utilize between 40 and 60% of the facilities that we build. And the reason for the variable, it depends on how many facilities we have. So there'll be cities, literally, like in Miami, where we would have 3 or 4 facilities where we may have a tremendous opportunity into anchoring with what we call a TCA or Total Care America doctor, but we may have more demand into the marketplace. One of the side benefits of what we're doing is a lot of doctors are realizing that their facilities are not efficient. The average doctor, certainly in the state of Florida, but applications probably everywhere, it has about 2,000 square feet. They pay about $4,000 a month. They have 2.7 employees. And what we're going to create is a much more efficient delivery system, both for ourselves, right, but also for doctors, so that we will be able to offer a doctor not just a physical real estate, but also on a per diem for their nurse or nurse practitioner or assistant, also do their billing, also do their staffing, also do their medical supplies. So you have to understand that healthcare is a very dynamic ecosystem. And it's not just a one component. A primary care is not just a component. It's all of the other things that are created. Right. So when we get done, right, we'll have 5 companies to start. But the reality is we'll have more than that. As we add on, in one of the slides, we showed it, it's slide number 21. Well, we add a billing company, which I've acquired many before. We hire a staffing company. We hire a group purchasing organization. All of those are components that we're going to offer the medical profession. So that's the way the components are done. And as we sell these companies, which is part of our goal to redeploy that capital, then we'll be looking at expanding into additional markets in healthcare. Again, the large market is $3.6 trillion. The government estimates that that'll be about $6 trillion by the end of the decade.
There's another question, and maybe this slide is good to keep it up here, which is, this seems very complex. Why hasn't it been done before?
Well, it actually isn't very complex. What we're doing is we're taking and going under the hood of this, and I'll use that analogy, sort of, it's a difference between an engine and a transmission and a differential and the GPS system. I've been in healthcare such a long time that I've seen all of these components. So I've operated 40 medical centers. Most of them, we didn't own any, but some of our doctors may have owned it. Real estate was a very big component. Technology has changed every industry on the face, the earth, except a couple. And we think the biggest one that needs to change now is healthcare. And the reason why it hasn't changed it yet is because you're dealing with separate companies, separate buckets. So one of the examples that I talked to is if a doctor is going to be using our platform and they would need a new button, they need a functionality in an EHR. They're not going to go out there and talk to the EHR company and try to contract to get it. And eventually the company may say, well, wait until we have enough doctors that want it and we'll do an update. So it could be 2, 3, 4 years out. Listen, all the doctor group has to come to me or to our management and says, we need this functionality in the EHR because we want this outcome. And let me tell you something. Our development team is going to get a call, possibly, that says, we need this functionality and we want it by the end of the next update cycle. So the reason why it hasn't been done is probably because no one's really understood the way all these components play together. I can tell you that going back to Oak Street, nothing that I read in their S1 told me they had bought any of those facilities. And they're going to find out that owning the real estate is fundamental, because the next time that one of their insurance company wants to put a big sign that says, welcome to Medicare enrollment, by the way, Medicare enrollment is right now open enrollment, they're going to have a problem with the landlord as to what they're doing. If they have too much traffic, they're going to have a problem with the landlord. All of those problems I've already experienced. They're using off-the-shelf technology. I don't care how good it is. They're still going to have issues in making the technology do what it wants to do. So there's nothing complex about this if you understand healthcare. So we understand every single component of this complexity. So whether it's, back to my analogy, whether it's the engine, the transmission, or the drivetrain, we know where it is, we know how to fix it, we know the role that it plays. And if you don't do this in healthcare today, you can't change it. It will not change until you have these type of models. And for another example, I can tell you the complexity in running a hospital system. I've been on the board of hospitals. Hospitals look incredibly complex. Why? Because you have housekeeping that manages the rooms, you have radiology, you have pharmacy, you have all of the components, pharmacy. All of those components are incredibly complex, but not if you're running a hospital. It is a byproduct of running a hospital. Guess what? We're going to be running a healthcare delivery system. It's not complex.
Thank you. Question that flips over to the data side. It's a statement and a question, I guess. Your technology platform is going to be generating a lot of data. How will you use that data?
Well, we're going to use the data in a couple of ways. First, we're going to use the data to inform the doctor. Remember, the only person that can really treat the patient is the doctor or his surrogates, whether it's a nurse practitioner, et cetera. So our number one use of data is going to give the doctor the information that they have. I've made it my mission when I've run medical practice to give the doctors the tools they have. So number one is going to be to improve the patient quality, number one. Number two is to what we call sort of advancing the science. So we are going to strip the data in certain cases and partner with other people that will be able to do the deep analytics. We have patents already on the use of that data. We've literally received patents on effectively a health and wellness score. So analytics is going to be incredibly important. We have two sides of analytics. One is inside sort of the wall of providing care to the doctors, and the other one is sort of the science and improving the science. We are confident that we will be able to take the data that we have from our payer partners, the HMOs, and we're going to give them back better data than they have today, because we're going to look at that first question sort of about connectivity. It's all about connectivity. So we'll be able to process certainly machine learning and AI into the platform, because we will have all the data. We will know every single dollar of every patient under our control, whether he is in our system, meaning in the primary care component, or he is at the hospital, or he is traveling, because eventually there's going to be a bill submitted to the insurance company or to us, and we will be able to process that data. So we're going in understanding that data is fundamental to our business product and fundamental to controlling costs and fundamental in advancing the science. So we're going to be on the cutting edge of data processing. We will have millions of encounter data from our patients.
I guess a follow-up to that, which is, why hasn't healthcare tech had the desired impact today?
Well, I could do a whole college study on that. And part of it is because of that complexity. So look at the graph that you've got. So you've got the primary care business here, which is total care, providing care to the patient, that generally would be connecting to a technology company. Now I can start at the top. I can start at Cerner, okay, which is sort of putting the new EHR platform for the Veterans Administration. I can talk to Epic, who I think actually has more hospitals than anybody else. I can talk to Meditech, which has a number of hospitals. Then I can go to Allscripts and anything else. What happens is technology companies have seen healthcare as a client. Okay, all of these companies are getting paid billions of dollars. The average installation of a hospital EHR is about $50 million. Some costing many times that. Okay, so what happens is everybody's looking at it as a client. We are going to be our own client. So that changes the dynamics. When Federal Express, it happens to be one of our examples, wants the better data, they go to their data team and says, we want better data. They don't have to go to an IBM, for example, or a third-party vendor that says, we need you to process this data a little bit different. The reason why healthcare technology has not affected healthcare to this day, no one can show us the proof that we've reduced the cost of healthcare or we've improved the quality of healthcare. In particular, let's just take a simple, okay, which is mortality rates. The mortality rates have not been impacted by technology, even though we throw hundreds of millions of dollars into the platform. And the reason is the relationship between the healthcare delivery system and technology is a vendor, client, supplier relationship. The irony of that is the first modern EHR was designed and built in a hospital in Massachusetts. So we're saying, and by the way, the companies that we talked about don't have it. We're saying that you could not separate the healthcare delivery from technology. So it's fundamental to our business model. We have built the technology, we have built the delivery system. So there's nothing here we have to learn. We know how it works. We will put this plan forward from day one that includes the healthcare delivery, includes the physical location, and includes the technology.
Great, thank you. There's a couple of minutes left, and there's more questions than we have time for, but let me just flip over to, I think, probably a good place to finish on the last couple of questions, which is relative to the investment side. How does the investment work at OXIO and the subs? What about future companies?
So the way we designed this, we tried to be simple, and if anybody has a better idea, we'd listen to it. The way we designed it is the money goes into OXIO as sort of the operating parent of the 5 companies. And we allocated, as we said in our slide, in the 6 different buckets. We expect that as we go to the next round, sort of the A round of this project, is that we will invest in these subsidiaries a material amount of money. As you saw in one of the slides, we expect that we can have Total Care at $180 million in run rate revenues with about $150 million investment. My goal is to do it a lot faster and a lot cheaper, but that's the idea. And the plan is that there will be not only investors that will want to invest in total care. Same thing with the real estate, the same technology. So we will be able to have almost like a captive venture capital operation, so that investors can allocate their investment. But today, the investment is 100% going into OXIO. OXIO is allocated as we're doing it forward. But we expect in the next round of financing, there will be some flexibility. And that's why we're allowing the investors to convert at a material discount to whatever the next round is, that we expect to be a minimum of $25 million. Most of that money, that $25 million, would be allocated to acquiring physician practices that we already would have in tow, and acquiring the real estate that we already have in tow. And I think from there, it becomes a really exciting model. As we sell these companies, and I guarantee you we're going to sell some of them, I would expect the first one probably be sold in 2022, 2023. So we need a couple of years under our belt. We would reallocate the money into the existing companies and certainly make the acquisition. Everything on the right-hand side there, future acquisition, is a done deal. We've owned billing companies, we've owned medical staffing companies, we've owned credentialing company, financial services, and insurance. So those are all things that we've already done in one of our companies in the past that we think we will plug into the system. For example, as I said earlier, today we're at the beginning of open enrollment. Open enrollment started October 15th, and I think ends through December 8th. In the past, we've had our own insurance agent working alongside with the insurance companies, selling and converting fee-for-service Medicare beneficiaries to our delivery model. So insurance, for example, is going to be fundamental, but we're not going to be selling it at large. We're going to be selling it to enhance our value. Instead of being passively waiting for the insurance companies to assign us benefits or beneficiaries, we're going to be converting and bringing beneficiaries into our delivery system. So think about it as sort of a hybrid. That's why DVP is a really interesting conversation, because by aggregating sort of an incubator, a venture capital, even a private equity structure, or even an open-end mutual fund, going forward into investing into this marketplace. I will guarantee you one thing: we're never getting this outside of healthcare, and we're not going to get into two components of healthcare. I can tell you right now. Okay. Maybe even three. We're not going to get into pharmaceuticals. We don't think that's where the opportunity is, certainly not where our experience is. And we're probably not going to be building any physical devices, because there's a lot of them out there. All we want is the data. At the end of the day, to the question somebody asked, is I want the data. I don't care about the device. I'll pay them $100 for the device. The data for us is worth tens of thousands of dollars. So that's the business model that we have. And we expect to build a company that is going to be driven by providing care, driven by how the care is provided, and the use of technology is fun. It's in our DNA. It's in my DNA, and it's in our DNA.
Last question in the last 30 seconds or so is, when do you expect to raise the 10 million on the bridge, and when do you expect to start the A?
I'm hoping by the end of the day today to raise the 10 million. So I think as soon as possible. I think that a lot of people have been waiting sort of what happens with COVID, not understanding there's tremendous opportunity. If we did not have COVID today, we would still be doing this model, but we paid 20, 30, 40% more for the doctors, and we paid 10, 20, 30% more for the real estate. So the opportunity is that today. You could argue, I think you'd be wrong, you could argue that the political uncertainty makes a decision better to wait. The reality is that I have advocated, I'd be happy to have a one-on-one conversation with anybody, that the opportunity is phenomenal today, again, in part because of the COVID opportunity. And if the worst case scenario, depending on who you are, or the best case scenario happens, it only gets better. I would love to have 20 more million people going into Medicare Advantage. Love it. It will dramatically change healthcare delivery today, because there's not enough capacity to do it. We'd love to be part of that solution. So thank you.
Yep.
Thank you, Paul. Thank you, Paul. Let's get back to you. Thank you, everybody, for listening.
Gentlemen, thank you so very much. And to all of our attendees, we thank you very much for joining us today. I will be following up with everyone. If there's any additional questions for the OXIO Health team, I would be more than happy to get you in direct contact. Gentlemen, again, thank you very much, and we hope everyone has a great day.
Thank you, Lindsay. Thank you, everyone.